Wonderful. So welcome to Online with the Experts. We're really thrilled today to welcome Dr. Perry Morocco, who is joining us from the University of Chicago, where he's an assistant professor, pediatrics and hematology oncology. He does research in the area of hematology and he's also a clinician educator who is active in the pediatric residency program there, and he's going to be providing us a talk today. Do you have your title slide? About neonatal coagulopathy and thrombotic disorders. So thank you so much for joining us.
Okay, well, thank you so much for having me. As I said, I'm Perry Morocco. I'm one of the assistant professors here, and we're going to go through a whole host of disorders and conditions. I have about 75 slides to go through, so I'll be talking fast. Please utilize the chat if there's something that, I said too quickly or didn't make sense. Oops. There we go. I have no financial disclosures, won't be discussing any off-label investigational use, and also the disclaimer of I'm not a neonatologist, I'm a pediatric hemonc doc, so I might be focusing on stuff that may not be the most relevant to you all, trying to base a lot of this on a lot of the consult questions I get or questions that have come up kind of during my time here. Okay, so outline, I really want to focus on just common patterns of coagulopathies in the NICU. I think that's important. Identify when a patient should be worked up for congenital or an acquired defect in hemostasis, and then also talk about when the thrombus is concerning for an inherited prothrombotic condition, or is that just something that, the baby got because they were quite sick? I love questions, so I'm just going to start with a few kind of pop quiz questions for the folks in the audience. Spoiler, I'm not going to reveal the answer, so just think about it. So you have an infant born at 31 and 6 to an G1P1 mother. They're admitted to the NICU for respiratory distress. There's a strong family history of hemarthroses among male family members on her side. And if this infant inherited this same disorder, what would you expect kind of their pattern to be of the coagulation labs? So normal PT and PTT, prolonged PT with a normal PTT, normal PT, prolonged PTT, or would both be prolonged? Next one. So neonatal coagulation systems are different. So what clotting factors have normal levels in newborns relative to older children and adults? Fibrinogen, which is factor 1, factor 5, 7, 10, or 13. And then kind of the last question is, what congenital deficiency, factor deficiency, has the highest rate of spontaneous intracranial hemorrhage? This is something that I know gets emphasized often on my board exams. I'm not sure if it's relevant to you all, but I think it's just something kind of practically helpful to know. All right, so keep these questions in mind. We'll be coming back to them, and we'll go through them at the end. So I'm talking about coagulopathy and thrombotic disorders. I'm going to start with coagulation and start with a review. I think this is often how people are kind of taught about the coagulation cascade. We have this intrinsic pathway, we have the extrinsic pathway, they converge. And then at the end, we have that stabilized fibrin clot. And based on if you have deficiencies or errors kind of anywhere along this pathway, that can then lead to a patient who's predisposed towards bleeding or kind of going too far on the other end. What I think about things, because this is actually just one piece of it, we have primary hemostasis. This is where the platelets are aggregating to form a platelet plug at the site of an injured blood vessel. So this is the first step. And that whole coagulation cascade, the formation of the stabilized thrombus with insoluble fibrin, that's secondary hemostasis. And the next piece of this is fibrinolysis, or, as the body is dissolving the thrombus, because you can have abnormalities in any of those, all of which are going to be clinically relevant. Kind of just showing this off in diagram form. So something happens, the vessel wall is injured, this subendothelial collagen is being exposed, the platelets are binding to it, and almost simultaneously, we're also getting this release of tissue factor. We're activating these coagulation cascades, depositing fibrin, and then eventually when the wet vessel has healed and it's no longer needed, that is all being degraded. And some of the tests, as you know, we've all probably ordered many times. We think about the extrinsic pathway that's encompasses with the PT and INR. That's looking at factor 7. The intrinsic pathway, or the PTT, is looking at our contact activation system. As then factors kind of going down the list, we have 12, 11, 9, and 8. It converges on this common pathway, which if there's abnormalities here, both PT and PTT will be affected. So for 5, 10, 2, and 1. And then we have the fibrin formation, fibrinolysis, which involves kind of less common players such as factor 13, alpha-2 antiplasmin, plasmin activator inhibitor 1, and then thrombin activatable fibrinolysis inhibitor. I mentioned that, you know, the neonatal coagulation system is very different from adults. In fact, most factors are actually decreased at birth relative to older children. This can be exacerbated when patients are born, you know, increasingly more premature. So neonates have decreased ability to actually form hemostasis from having just decreased synthesis of a lot of these factors floating around. Their platelets aren't really working as well as they should. They also, on the other side, they also have lower levels of the body's natural anticoagulants, our protein S and C, as well as their fibrinolytic system is hypofibrinolytic. So they're not as good as breaking stuff down. And this comes into play because oftentimes if we are working up a patient for a congenital bleeding disorder, when we're looking at kind of their factor levels, usually whatever is in the system is going to get flagged as abnormal and oftentimes requires being cross-referenced against, you know, tables that have shown either by gestational age or weeks or the baby, how old they are in weeks or months, have what the expected levels would be. So I'm going to first start by talking about coagulopathies. You know, just as some epidemiology, any baby who's admitted to the NICU has about a 25% chance of having some episode of bleeding, ranging from mild to very severe and life-threatening. As their gestational age decreases, the risk of that increases, and, you know, the intraventricular hemorrhage, you know, as you all know, is fairly common. About 23% chance of that occurring if an infant is born under 32 weeks gestational age. Some other risk factors that increase this would be if, you know, the baby has a lower birth weight, they have a PDA, or they ever have a diagnosis of sepsis. So just starting to think about all of these disorders, I'm going to first talk about quantitative disorders of primary hemostasis. So remember, primary hemostasis is the platelets forming that initial plug. You know, broadly breaking this down, we have things that impair platelet production. We have neonatal alloimmune thrombocytopenia. We have ITP in the birthing parent. This is sometimes known as neonatal autoimmune thrombocytopenia, but the acronyms don't work out as well. So I mostly just call this like maternal or birthing parent ITP. We have congenital neonatal infections, congenital thrombocytopenia syndromes, then preeclampsia and medication side effects. So neonates, they don't really produce platelets similar to how adults or older children do. They actually increase their overall numbers to be at the adult level by about 22 weeks gestational age. However, they rely on a lot more of their thrombopoietin, which is the growth factor for megakaryocytes, which is the cell shown over here. Megakaryocytes are the precursors to platelets. And unfortunately, their megakaryocytes don't produce as many platelets per cell as an older child or an adult does. So if there's ever a condition where they're exposed to hypoxia, maybe some intrauterine growth restriction, or some respiratory distress after birth, that can impair their thrombopoiesis, as well as they can't respond as well to high demand states. So if there is a vascular injury, if there is sepsis, they're very likely to drop their platelet count. And that ranges a little bit from some of the studies I looked at, but roughly about 50% of infants with sepsis will develop actual thrombocytopenia, with it ranging from being, you know, severe to under 50 to being more kind of milder, 100 to 150. So let's talk about neonatal alloimmune thrombocytopenia, or NATE. This is thankfully pretty rare, about 1 in 1,000 births. It is the birthing parent is recognizing antibodies on the infant's platelets. And then as these antibodies get transferred over, the platelets are destroyed. It can happen pretty early at 15 weeks gestation. And one of the key things to know is that this worsens with subsequent pregnancies. You should consider this on your differential whenever you have an infant within 48 hours of delivery has thrombocytopenia to a platelet count below 50 in the absence of other signs. So there's no blueberry muffin rash, you're not concerned about sepsis, there's no other reason why this baby should be thrombocytopenic. And the actual diagnosis requires a fair amount of blood, but basically we bring the parents in and we do platelet immunologic testing of both the parents. The most common antigen depends a little bit on the ethnic background. It's human platelet antigen 1 if they're Caucasian, or 4 if they're Asian or Asian American. The reason this matters is because you don't want to just transfuse platelets that maybe have some of the paternal antigen on it. So, I mean, ideally, the birthing parent could donate platelets. Sometimes that's not possible. So our blood bank colleagues will utilize kind of the patient's ethnic background to determine the platelet transfusion. Generally, if it's a Caucasian patient, they will be able to screen for HPA-1 negative platelets for transfusion. Whenever the platelets fall below 50K, these patients should get head ultrasounds, and then they should be transfused platelets if the platelets fall below 30. These are just some images of a baby born with NATE. You can see that they have this diffuse ecchymosis and some petechiae, and as well as, unfortunately, did develop an intracranial hemorrhage. The incidence of this in NATE is actually fairly high, 7 to 26%, and when it occurs, it can be fatal in about a third of patients. So definitely something to be aware of. This is contrasted, though, with if the birthing parent has ITP or immune thrombocytopenia. Similar mechanism, we have these antibodies that are transplacentally transferred to the fetus. The platelet count typically naters around 3 to 4 days, so we need to be following it consistently and can take a while to normalize, normally about 4 to 6 weeks. The thrombocytopenia here can be very variable. I've had patients where it's dropped down to like 20 or so, other ones where it just dips a little bit to like 80 to 100 and then recovers. Unlike NATE, even though if the platelet count is about the same, intracranial hemorrhage is fairly rare, 0 to 1.5%, which actually matches kind of older children with ITP, what they have. And if they have bleeding symptoms, it's overall more mild than NATE. The one thing to be aware of with this is even if the mother is in remission from their ITP and has a normal platelet count, there can still be a transfer of antibodies that are not causing issues, in the birthing parent. They can still make their way to the fetus and cause thrombocytopenia. But generally, kind of a good screen would be if the birthing parent's platelets are low at the time of delivery, then, more likely that this is going to be an autoimmune versus an alloimmune process here. Treatments for this, we can give IVIG, generally don't do steroids as much. And if it's autoimmune, with ITP, if you give platelets, that tends to just add fuel to the fire and they tend to be chewed up, versus NATE, where giving platelets, as long as they're matched appropriately, those platelets should last. However, keep in mind, when we transfuse platelets, they only have a half-life about 2 to 3 days, so the infant might require multiple platelet transfusions. Moving on to other kind of quantitative disorders, congenital infections. I'm willing to bet everyone here knows a lot more about this than me, so I'm really going to fly through this. So CMV can do this, associated with sensory neural hearing loss, microcephaly, SGA infants, toxoplasmosis, they might have hepatosplenomegaly, jaundice, seizures, intracranial calcifications, rubella, congenital glaucoma, there should be intrauterine growth restriction, purpura, congenital heart defects, as well as HIV, which I do say causes failure to thrive, but the new name is growth faltering, as I learned a week or so ago, sepsis, thrombocytopenia, and HSV, which can present with either localized or disseminated infections. These can actually occur fairly late, up to 6 weeks of age. And you'd be more likely to think about this if this patient has severe coagulopathy, thrombocytopenia with acute liver failure. And really, as you treat the underlying condition, the platelets, will recover in time. And as mentioned before, the newborn bone marrow is very sensitive to stressors, and so any type of infection can cause the platelet count to drop. I've had a number of consults where they call me and, to evaluate a thrombocytopenia in an infant who's maybe a couple weeks old. Then talking to the nurse, the baby's having more, APDs, or is having some desaturations, they're requiring up titrating their vent settings. And usually that kind of the day or so that blood culture turns positive is usually about, within 24 hours of when we started seeing the platelet drop. So it can be fairly time sensitive. There's also congenital thrombocytopenia syndromes. Look at this kind of newborn infant here. We have some abnormalities. I'm not monitoring the chat, but just, say aloud or think to yourself, what condition might this baby have? And if you thought TAR or thrombocytopenia absent radii, you are correct. So this is a great syndrome because the name tells you what you need to know. They are missing their radii bilaterally. Importantly, they will have normal thumbs, which differentiates it from some bone marrow failure syndromes, which often have abnormal thumbs. They'll have bleeding, purpura, and intolerance of cow's milk. Interestingly, for these patients, that their thrombocytopenia generally gets better with time. It's most severe early on in life. Other congenital symptoms, we have A, megakaryocytic thrombocytopenia. This is also autosomal recessive. It's from C-MPL mutations. That is the thrombopoietin receptor gene. So if they can't respond to the growth factor, they won't really be making it. They can have a whole range of phenotypes, but usually will have purpura petechiae in the first month of life. And these patients are going to require a stem cell transplant because they can progress into aplastic anemia as well as leukemia. Usually they won't be born with that, but kind of we follow them closely for that. And then the other one is Wiskott-Aldrich syndrome. This is X-linked and kind of has that classic triad of thrombocytopenia, eczema, and immunodeficiency. A buzzword here is that these have small platelets, which differentiates it from some other syndromes I'll talk about in a little bit. And the mnemonic I learned in residency when studying for this is EXIT for eczema, X-linked, immunodeficiency, and thrombocytopenia. These patients can also have growth faltering with this and, our increased risk of infections from their immunodeficiency. Continuing with the quantitative platelet disorders, preeclampsia, the most comprehensive related complication. Not only does this cause endothelial dysfunction within the newborn, but causes intrauterine hypoxia, which then causes decreased megakaryocytes. They can't respond as much, so this can be pretty common. Incidence in any given birthing parent is about 2 to 6%, so it can be fairly common. And this effect is worsened if the baby is SGA. And then other ones is any medications. That's the common ones here are antibiotics, heparin, phenytoin, and indomethacin. This is usually done via immune-mediated mechanisms that I won't really get into, but just be aware that sometimes we do have to switch around the drugs patients are on because they can cause thrombocytopenia. This is a nice review that came out just last year in Blood, and it kind of goes through your differential diagnosis if you have a fetus or neonate with thrombocytopenia based on kind of when it presents. And what they bolded here are the more common ones. So they break it out into fetal, early, within 72 hours, and late. This all just kind of gives an idea of all of the disorders. So I didn't talk about all of this. Yes, maternal like lupus, Kawasaki disease, all those can play a role. Trisomies and metabolic conditions can also cause this, but generally with those, there will be other signs and symptoms. And I will probably not be the most helpful person in diagnosing something like a propionic acidemia with that. But something to keep in mind. So those were quantitative disorders. We also have qualitative ones. So we have qualitative platelet disorders, von Willebrand's disease, congenital thrombotic thrombocytopenia purpura, or TTP, as well as collagen vascular disorders. Because remember, that first step is when the endothelial lining is damaged, they're exposing collagen, and that's what the platelets are binding to. So for a qualitative platelets disorder, you really want to suspect this when there's a normal platelet count, but they're having just bleeding that is just, not quite matching up. The two ones here that we think about are Glanzmann's thrombocythemia. This is autosomal recessive. This is your defect in glycoprotein 2B3A, or Bernard-Solier syndrome. This has an absence of the glycoproteins 1B. 5, and 9 on platelet surfaces, so they don't adhere as well. And unlike Wiskott-Aldrich, where the platelets are small, here, the kind of the buzzword here are large or giant platelets on the peripheral smear. Since most of the time you all probably aren't looking at peripheral smears, so here's from the ASH image bank, you can see just in comparison to a red blood cell, these are platelets, kind of these little dots spread throughout. You can see that, they're usually much smaller. However, in patients that have either of these conditions, they have large platelets, which are much bigger than this, but smaller than red blood cell, or giant platelets, where they're actually the same size of or larger than a red blood cell. To make this diagnosis, there's some specialized testing that needs to be done that your hematology colleagues will help you with. There's also something called gray platelet syndrome. So just going back, notice how these platelets kind of have stuff within, they're staining darker. That's all the granules they have within. Gray platelet syndrome, they have this washed out appearance because they're not having alpha granules. There's kind of dense granules and alpha granules within platelets that play different roles in kind of the platelet function, and platelets degranulate when they become activated. These patients with gray platelet syndrome will have a macro thrombocytopenia. You can see here, once again, we got large platelets again. They'll have splenomegaly, and then they'll have, it's usually a mild to a moderate bleeding diathesis. The other one to think about is, so this was a lack of the alpha granules. If they're missing the dense granules, that's a condition called Hermansky-Pudlak syndrome. This is autosomal recessive. They have other features associated with it, occutaneous albinism. They have pulmonary fibrosis, which is usually long-term, will cause a lot more morbidity, mortality, vision abnormalities. And then we make the diagnosis by looking at their impaired secondary aggregation on platelet studies, or as well as with electron microscopy, you can see that they don't have dense granules. This syndrome is interesting because while it's not too common among most kind of ethnic groups and backgrounds, in patients that are of Puerto Rican origin due to a founder effect, it's actually pretty common. It's found in 5 of every 6 patients with albinism in Puerto Rico, which is the highest, in the world. And it's about 1 in about 2,000 patients. For von Willebrand's disease, just very quickly, so von Willebrand's is a glycoprotein that helps the platelets adhere to the subendothelium. They also stabilize factor VIII. We have 3 different types, which is really more because it's kind of broken down into lots of subtypes of type 2. But 1 and 3 are easy. 1 is a partial quantitative deficiency, so they just don't have as much. 3 is they have none. These patients act a lot like patients with hemophilia, which I'll be talking about later. And then the qualitative defects for von Willebrand's disease are all the type 2s, which I don't think is probably, at this point, if you're worried about von Willebrand's disease, likely hematology is involved, so I'm not really going to go through all of these types too much. The one thing I will say is if you're ordering a testing for this, oftentimes, I know here at University of Chicago, we have a panel, but if there isn't a von Willebrand's panel, please make sure you're ordering both an antigen level as well as activity, because I've had referrals, this is usually more in older kids, where only one is ordered, and then they're coming to see me for epistaxis or menorrhagia, but definitely we need both in order to kind of see what the pattern is, as well as make the diagnosis. Treatment in a neonate if they have von Willebrand's disease, because DDAVP is contraindicated if they're under 2 due to the risk of hyponatremia from the fluid restriction, but there's a von Willebrand's factor that can be given. Okay, now we're kind of in some of the rare conditions, but congenital TTP, if you remember, this is that Adams TS13 metalloprotease. If patients are missing this, which the acquired form is much more common and kind of has that classic pentad of fever, hemolytic anemia, thrombocytopenia, renal and neurological dysfunction, the acquired form is much more common. But you can also have a congenital disorder. These patients are going to have both hyperbilirubinemia from all the hemolysis, they'll have thrombocytopenia, and because of all of their microvascular dysfunction, they're also at risk for thromboembolic events despite having thrombocytopenia. The other kind of big category is collagen vascular disorders. If you have mutations in collagen, these can cause renal disease, they can cause intracerebral hemorrhage, myopathy, as well as ocular abnormalities, because collagen plays an important role there. Ehlers-Danlos syndrome, these patients have easy bruising and bleeding. They'll often have this skin or joint hypermobility, as well as they can have spontaneous hematomas. And then Oslo-Weber-Randall syndrome, this is an autosomal dominant condition. They'll have AVMs in their lungs and liver, high risk of bleeding, as well as they can have telangiectasias in different parts of their bodies. So you might actually see this on like their lips, fingertips, or within the buccal mucosa. So you have a patient with a number of kind of AVMs, or if they're just seem to have spontaneous hemorrhage within their lungs, as well as some other telangiectasias, I would have a high index of suspicion for Oslo-Weber-Randall syndrome. All right. Trying to stay on time and about halfway through slides and halfway through time. So secondary hemostasis. So I'm not going to go through every single factor deficiency. As you can imagine, with anything within the coagulation cascade, the abnormalities there can result in bleeding and coagulopathy. Going to be focusing more on kind of the big ones, which I'm highlighting as, vitamin K deficiency, and our hemophilias, and then factor 13 deficiency. So vitamin K deficiency, really since, the 60s, the AAP has recommended that all newborns get an injection of vitamin K to prevent what they called hemorrhagic disease of the newborn. When I looked as of this morning, I could only find 4 states that this was mandatory in: New York, Maine, New Jersey, and Oregon. A lot of other states, it's highly recommended, but not mandatory. If anyone listening is from Illinois, it was actually mandatory here, and then parents were having DCFS called on them, and then they sued, and then that law got revoked. But without vitamin K, infants are at high risk of bleeding in their first 6 months of life. They don't have a lot of vitamin K stores. Their gut flora can't produce the vitamin. And, just as a refresher, we need vitamin K to produce factors 2, 7, which I bolded here, 9, 10, as well as proteins C and S. Of all the factors, factor 7 has the shortest half-life. So if someone is vitamin K deficient, factor 7 is going to be the first one to go down, which kind of then going back to the coagulation cascade, we're going to see then our abnormalities in our PT INR first before we see it eventually in the PTT. All right, so vitamin K deficiency bleeding is broken up into 3 types. We have early, classical, and late. Early is in the first 24 hours, classical within the first week after the first day, and then late is basically, kind of weeks to months later. Early is primarily seen if the birthing parent is on the medication that's going to interfere with vitamin K, warfarin being kind of the big one, but as well as some anti-epileptic drugs or drugs that work against tuberculosis. These patients will have intracranial hemorrhage, it's bleeding from their umbilical stump. They might have cephalocematomas. And if the infant is at risk, or they have the maternal, the birthing parent has these exposures, the incidence of bleeding is about 6 to 12%. For the classical one, this is usually because, can still be due to medications, but it's likely due to insufficient vitamin K after birth or refusing the injection, and is at increased risk in infants that are exclusively breastfed. Similar kind of pattern, except they might have their increased risk of having bleeding from their GI tract, still kind of umbilical stump bleeding, as well as if it's a boy that gets circumcised, might have bleeding from that. Without vitamin K prophylaxis, the incidence is actually lower. It's about, less than 1 to almost 2%. And then in the late form, this can be seen in folks that don't get their vitamin K injection, or if there's anything that would cause poor absorption. So a lot of conditions here: biliary atresia, cystic fibrosis, pancreatic insufficiency, if there's some other cause of growth faltering that's causing chronic diarrhea, that can all cause this. This actually has a fairly high rate of intracranial hemorrhage, can be 30 to 60%, as well as still having that GI and mucocutaneous bleeding. And I should say this 30 to 60% is if they do have bleeding, this is what you expect from intracranial hemorrhage. Incidence is a little variable based on what study you look at, but somewhere between 114,000 to 25,000 infants. There is some literature coming out that if you are fully compliant in doing an oral course of vitamin K, that can actually be just as efficacious as the injection. However, because you typically have to take that at like 1 day of life, 7 days of life, and then 28 days of life, the compliance isn't great, which then still causes the increased risk of all of these complications. So still the recommendation is really everyone should just get the IM shot. All right, hemophilia. So these are X-linked disorders. We have factor VIII deficiency, which is hemophilia A, factor IX, which is hemophilia B. Of these, hemophilia A or factor VIII deficiency is more common, 1 in 5,000 versus about like 5 in 100,000 males. Family history is helpful, but 30% of the mutations for hemophilia A are de novo, so can just kind of appear out of nowhere, unfortunately. The phenotype is based on factor levels, so mild is 5 to 40%, moderate is 1 to 5%, and severe is if they have under 1%. The ones that will probably come to attention soonest are those with the severe phenotype, really high risk of neonatal bleeding. They can have intra or extracranial hemorrhage. They can have bleeding from their circumcision site, as well as kind of that classic spontaneous muscle hemorrhages that we think about and that cause a lot of morbidity long-term. Treatments for these is factor replacement, as well as if it's kind of for mild disease, you can do desmopressin, DDAVP when they're older, because von Willebrand's for hemophilia A, von Willebrand's and factor VIII go together, which is why if you have type 3 von Willebrand's disease or a complete absence of von Willebrand's proteins, they act a lot like someone with hemophilia A, because without von Willebrand's, our natural factor VIII gets degraded, pretty quickly. And then one thing we don't think about a lot is factor XIII deficiency. So this is very rare. There's probably at any given time about 100 patients in the United States with this condition. I have one patient here at University of Chicago with it, and I'm not sure when we had the last patient with it, but from what pharmacy told me, I'm the first doc here to ever order basically factor XIII as an infusion. So we can't have too many with it. But these patients, factor XIII comes in later in the coagulation cascade and helps stabilize by cross-linking fibrin strands. So you can form a clot, it's just the clot is weak. So these patients have rebleeding. So they might have bruising, umbilical cord bleeding, soft tissue hematomas. My one patient, was seen in the NICU, got circumcised, had some oozing afterwards that stopped, and then over the next 24 hours after discharge, presented to the emergency room 3 different times for persistent oozing, and then was unfortunately readmitted in basically hemorrhagic shock from losing so much blood. And this takes a while to make the diagnosis because the platelet count will be normal, and because it's so further down in the coagulation cascade, they have normal PT, INR, and PTT. And just to kind of a trivia note, but these patients have the highest rate of intracranial hemorrhage of any bleeding disorder. So when my patient, when the family told me that they were having, another child, given that it's autosomal recessive, so 1 in 4 chance, we talked with the L&D as well as the pediatricians at the hospital where the mom gave birth to say, please send this blood out ASAP, and then give, the baby cryoprecipitate. Cryo has within it fibrinogen, it has factor VIII von Willebrand's, and it also has factor XIII, and it has more of that than you get with like FFP. This, though, can take a while to make the diagnosis just because so many labs are normal and you have to do send-outs to get this. All right, fibrinolysis, these disorders are even more rare, but if you have some issue with the fibrinolytic system, then you can run into bleeding disorders. So you can have qualitative or quantitative disorders, defects in fibrinogen. You can have a plasminogen activator inhibitor 1 deficiency or PAA1 deficiency, and then alpha-2 antiplasmin deficiency. Whenever you're getting to this point, likely I'd expect hematology is probably already involved. Fibrinogen disorders, very rare. You have mutations in the genes that produce fibrinogen. Patients who have hypo or dysfibrinogenemia tend to have a mild bleeding tendency, or sometimes they're completely asymptomatic. The ones that are likely to come to attention in the neonatal period or in the NICU are patients with afibrinogenemia, so they don't have any. They often have bleeding from their umbilical cord or after interventions. So you gave them the hepatitis V and the vitamin K, and then they're going to, have the bleeding then. They won't kind of appear and be born with, purpura and ecchymoses as often. Interestingly, this is a condition, if they have a hypofibrinogenemia, is there actually an increased risk of thrombosis as well as increased risk of bleeding, because if they don't have fibrin, the antithrombin function, is impaired. These patients you can treat by giving them fibrinogen concentrates. You can give them cryo, fresh frozen plasma, as well as, if they have the more milder bleeding tendencies, you can give them antifibrinolytic drugs, which is TXA or triamcinolone acid or Amicar. Plasminogen activating inhibitor 1. So this inhibits fibrinolysis by inhibiting our UPA or TPA. Show the diagram here because I often have to, kind of draw this out when explaining it to folks because there's a lot of steps involved. So similarly, these patients, can form clots, they just degrade pretty quickly. I have one patient that I follow with this who overall does very well, except every time they need an immunization, they need to come see me. We give FFP, we give them Amicar IV, and then we watch them for a few hours afterwards to make sure they're safe to go home. My patient actually presented because they were doing perfectly fine. There was anecdotally noted, had a bunch of oozing with their vitamin K and their hepatitis B vaccine, but then when they got their 2-month immunizations, they basically just oozed from those for about a day and presented to the ED with like their onesie just completely soaked in blood after they woke up from a nap. Similarly, these patients have a normal PT and APTT, so challenging to make the diagnosis, and then particularly after trauma or surgical procedures is when they're likely to have bleeding. Medications like the triamcinolone acid and Amicar, which inhibit fibrinolysis, are very beneficial here. And then if they're needing something more invasive, we'll be planning likely for them to get FFP. I actually have not seen a patient with alpha-2 antiplasmin deficiency thus far, but this is also pretty rare. Alpha-2 antiplasmin inhibits plasminogen and plasmin, whose function is to degrade fibrinogen. These patients can have bleeding that can resemble either hemophilia with spontaneous bleeding or factor 13 deficiency, because as the theme of this is, they got normal PT and PTT. They have bleeding after trauma, and this is inherited in an autosomal recessive manner, so it can kind of hide away. But this is rare. Read case reports about it, but I've been 3 years of fellowship. I'm going into my 3rd year of being an attending, but I've not actually seen a patient with this yet. All right, so that's a lot of congenital conditions. Talking about acquired coagulopathies, I'm not going to touch on DIC and liver disease all too much. DIC is they have something going on, maybe it's sepsis, some other condition, so they're kind of using up a lot of their clotting factors, as well as their hemostatic factors, such as their protein S and 3 and antithrombin. The liver makes a whole host of our clotting factors, so if you have liver disease, that will be impaired. I want to spend a little more time on HLH and vascular anomalies. So HLH is incredibly rare in the NICU. There was a study that looked at this HCUP kids inpatient database from the years 2009, 12, and 2016, which encompassed about they looked at everyone who either died or was discharged from the NICU. It was over 11 million patients. And of those 11 million, 76 had HLH. So 11 million over 3 years. And this encompassed most states in the US, about 44. So very rare. When it does occur, though, has a fairly high mortality rate at 42%. The diagnostic criteria is you either need to have a genetic mutation of an HLH-associated gene or at least 5 of the following. So fever, splenomegaly, at least 2 cytopenias, hypertriglyceridemia and or hyperphagocytonemia, hemophagocytosis, lower absent NK cell activity, ferritin over 500. But remember that ferritin is an acute phase reactant. So, if you have someone who's sick, that is going to go up and it won't be as beneficial. As the numbers go higher, it becomes a little more sensitive. So folks that I've seen with HLH usually have it, in the thousands or tens of thousands, and then have elevated soluble CD25, which is the interleukin-2 receptor. In the neonatal setting, if it's not familial or primary, which is due to genetic mutation. If it's secondary, interestingly, HSV is the most common infection associated with it, associated in the neonatal setting with about 16.6% of cases, more so than MRSA, CMV, enterovirus, EBV, and adeno. Little unclear as to why that is the case, but something to think about if you have a patient with HSV infection who kind of doesn't seem to be following the rule book and getting worse and is really having just a lot of diffuse inflammation despite what would be considered appropriate treatment. So that's HLH. For vascular anomalies, so this whole host of different conditions, but you have abnormal development of either your lymphatic system, your veins, your arteries, or your capillaries. The 3 ones we think about are caposiform hemangioendothelioma, or KHE, tufted angiomas. Both of these are benign vascular tumors, or a lymphatic malformation called caposiform lymphoangiomatosis. The main thing here, and the buzzword here, is Casabat-Merrick phenomenon, where they're just consuming all of their platelets and coagulation factors, putting them at very high risk for bleeding. This is seen in about 70% of patients with KHE, much smaller percentage, 10 to 20% of patients with TA. Couldn't find any good statistics for the caposiform lymphoangiomatosis, but it's likely somewhere between a KHE and a TA. So these are just some pictures I pulled up from online. This is a patient with a caposiform hemangioendothelioma. You can see it kind of has this taut, very red appearance. With it, these patients are going to have elevated D-dimer, their PT and PTT are going to be prolonged. And one thing to note here is I've had patients who, couple patients with this, the one that had early on in fellowship, this was a baby born at another institution. They saw that the platelet count was very low and this patient had this abnormality in their shoulder area. They, to fix the platelets of, it was like, single digits, like, 5 or 6, they gave platelets and then they noticed that the lesion was swelling more and more. You can actually cause a compartment syndrome if you keep giving products to these patients in the absence of any, bleeding. So that's one piece just to be aware of here. And whenever a patient has anything concerning for this, it's also very helpful to get an MRI because these can be very locally aggressive and burrow into deeper structures. So while this patient looks like it's mostly in their arm and shoulder, there might actually be some infiltration into the chest wall or thorax here. Tufted angiomas are usually a little more superficial. This is a patient, with it. They, usually less dramatic of an appearance. And this is a patient with a caposiform lymphoangiomatosis. This is often found, deeper within the soft tissues, likes to be in the thoracic cavity. And unfortunately, this can often progress and, worsen, which can cause a lot of morbidity and mortality. Treatments for these are usually some combination of resection if possible. You can give vincristine, which is a chemotherapy agent, a vinca alkaloid. You can give sirolimus as well as steroids. And at least here, usually it's some combination of us, surgery, and dermatology that's helping kind of manage the KHE and TAs. Have not seen a patient with a caposiform lymphoangiomatosis thus far, but dermatology, I think, is still involved, but different institutions might have different subspecialty involvement. All right. Common laboratory patterns with this mentioned that in kind of early vitamin K deficiency because factor 7 has the shortest half-life, and that is tested within PT. Early on, the PTT will be normal here. If the vitamin K has been going on for a while, then both will actually end up being prolonged. You'll see prolongation of both with DIC, liver disease, anything that affects the common pathway, or sometimes patients might have a, say, factor 7 and a factor 9 deficiency, which will do it. Here, if just the PTT is prolonged, remember that a lupus anticoagulant, which is a terrible name because it's not an anticoagulant, it actually increases your risk of thrombosis. Talk about that in a bit. But at least in the lab, it artificially kind of causes prolongation of your PTT. This is something where a mixing study is helpful. If the mixing study does not correct, you're worthwhile to send lupus anticoagulant testing. If it does correct, thinking much more of a factor deficiency. And just be aware that there are some serious conditions, such as factor 13, which has the highest incidence of intracranial hemorrhage of any bleeding disorder. Basically all your testing will be normal, as well as that can be seen in patients with thrombocytopenia and some of the other conditions we talked about, such as PAA1 or the alpha-2 antiplasmin. All right, 12 minutes left, and I really want to leave some time for questions. So thrombotic disorders, these are as well, they are fairly common. One thing I get consulted about is, hey, does this patient need a hypercoagulable workup? Or is there some underlying risk that predisposed this patient towards developing a thrombus? Or was it that they're a sick infant born at, say, 22 weeks? So the initial labs, it's a lot. And there might be other ones based on the clinical situation, but usually antithrombin 3, protein S and C, factor V Leiden, which is testing for activated protein C resistance, prothrombin mutation, lupus anticoagulant, and homocysteine. Now, the problem with this, and what often, kind of requires us to break this up, is this is a fair amount of blood. If you were to send all of this to Mayo Clinic, because this was the easiest way for me to search and see, these tests alone are usually going to be somewhere between 12 to 15 mils of blood, which can be problematic, if you have a small infant. Other tests that you might consider ordering are a factor 8 level, as well as a lipoprotein little a, kind of all just depends. But definitely likely going to be hitting these unless the family comes and says, we have a whole host of family members that have factor V Leiden or, elevated homocysteine levels. So thrombus in the NICU is fairly common and is unfortunately increasing over time, likely because of the better outcomes we have with increasing prematurity. In 2007, which was the last time I found this, in about 10,000 admissions, instance about 75, can actually have a fairly high mortality rate, 2 to 4%. And really the main thing is an indwelling central venous catheter gives you the highest risk. Prematurity increases your risk if they have any invasive procedures, congenital heart disease, erythropoietin level, all of this can do it, but really the indwelling central venous catheters. This is an analysis of this Pediatrix medical group database. They looked at all of their NICUs from 1997 to 2015, which was a total of about like 1.2 infants. And this is, at least in this study, they found that, certainly from the 90s, it's gone up, over time. All right, to mention that indwelling catheters are the most likely cause. They actually cause about 90% of neonatal thrombotic events. Anytime a patient has a UAC or UVC, those confer different levels of risks. You start actually forming a thrombus or fibrin around the line within really hours of it. And if there's anything else, such as other vascular endothelial damage, say you have the infant is septic or some other inflammatory process, this can result in a clot. As your duration of line placement goes up, if there's any perinatal asphyxia or in babies that have neck, kind of risks go up. Thought to be due to, as talked about before, that we have this immaturity of the clotting system, as well as their hemostatic system is kind of out of balance initially, and it's very easy to kind of tip it all the way over the edge. Other things to think about is nephrotic syndrome. When the patient has nephrotic syndrome, they have increased platelet activation. They're actually losing some of their natural anticoagulants, such as antithrombin, protein S and C, as well as to compensate, they're making increased levels of fibrinogen factors 5 and 8. So that's one thing to think about. There is a congenital nephrotic syndrome. It's very rare unless both parents are actually of Finnish descent, where similar thing, founder effect, the incidence is about 1 in 8,200 live births. Antiphospholipid syndrome, mentioned this before. This is an antibody-mediated hypercoagulability syndrome. Usually it's going to be accompanied by thrombocytopenia and or hemolytic anemia. Remember here that this would be in the mixing study, that you have a patient with a normal PT-INR, their PTT is elevated, and when you do a mixing study, the PTT does not correct. These antibodies bind and activate endothelial cells. They also do the same for neutrophils and platelets, resulting in a lot of pro-inflammatory cytokines and chemokines, as well as activating complement, which is how it can cause this. You can, though, have a transient, usually seen more in older patients, but you can have a transient kind of like antiphospholipid antibodies that usually we just have to check about 3 months later to see if those are going away. Based on where you work, they might kind of break it down. There's like cardiolipin ones. If someone is triple positive or they're positive for basically all the 3 months we test, they're at the highest risk of actually forming clots here. Yeah, as mentioned, mixing studies are beneficial. I just thought, because, I tend to think about antiphospholipid syndrome when pediatric patients, not necessarily in the NICU, but just as mentioned before, we're kind of activating all of these different parts of the body, a lot of inflammation, which then results in coagulation. All right, otherwise, congenital thrombotic disorders, these are all fairly rare, and really acquired is much more common. I quite rarely in the NICU recommend that we send a hypercoagulable workup. Usually you can identify something. This patient, arrested, they had an accidental extubation, they were born, to a parent with chorioamnitis, they're bacteremic. Usually that we can find a good explanation for it. But, if there's a strong family history or there was really nothing that we think about triggering it, certainly worth sending the hypercoagulability workup. So as I mentioned, these are rare. We can have deficiencies in protein S and C. These are autosomal dominant, but have incomplete penetrance. If they're homozygotes for the deficiency, they're much more likely to have the severe symptoms, or being a compound heterozygous. These patients are going to have DIC or neonatal purpura-fulminans after birth. And they can also have prenatally kind of retinal, renal vein, or cerebral vessel thrombosis. These are some pictures I just found online of infants who are born with this. Notice how this primarily affects the extremities, but can affect any part of the body. And typically this is going to present within a few days of birth. So if this is someone who's, months old and developing this, I'd be concerned that, something else is going on here. Antithrombin 3 deficiency is also quite rare, but has autosomal dominant inheritance. The key thing here is these patients are going to be highly resistant, to heparin treatment. So they form a clot, you put them on Lovenox or a heparin drip, and then still, they're having clot propagation, or they're developing a pulmonary embolism. This is tricky to diagnose because when infants are born, their antithrombin levels to begin with are much lower than those of adults or older kids, about 56% of adults. And if it's a premature infant, it's even lower. Factor V Leiden, autosomal recessive, most common risk factor for VTE in folks that are Caucasian. Key thing here is Budd-Chiari syndrome is classically associated with that. And so that's kind of the buzzword to think about here. If they have a prothrombin gene mutation, this is autosomal dominant. They are at increased risk of arterial thrombus. And that's because they're just producing a lot more prothrombin, and they can also have thrombi within the CNS. Thrombocytosis is something I've often get consults on as well. So this is a peripheral smear. You can see that this patient has lots of platelets all throughout, including some that are actually on the larger side, comparing them to the size of a red blood cell. This can be primary or secondary. Secondary is usually due to infection, inflammation, and we see more in patients that are born premature. Key thing is that this is a benign process. While there are case reports of having like a reactive thrombocytosis that then developed a thrombus, that's incredibly rare. And, I would say we would not kind of recommend any sort of treatment or prophylactic anticoagulation for these patients. What's also incredibly rare is a primary thrombocytosis. These are patients that generally have something like essential thrombocythemia or any myelodysplastic syndrome. Very, very rare. It often presents in patients that are over 50 years old. This is associated with an increased risk of arterial thrombus and MI, although most patients are actually asymptomatic. All right, so for at least thrombotic disorders, think of the history and the clinical scenario to see is this provoked or not. And if it's unprovoked, then that's really when it's worth saying hypercoagulable workup. Since this would actually fit in the page, I just put kind of the buzzwords here. Think of indwelling catheters, protein S and C deficiency, neonatal purpura fulminans, antithrombin 3. Heparin isn't going to do anything because you need antithrombin for that to work, factor V Leiden, but Chiari and unprovoked arterial thrombus for prothrombin gene mutations. Talking fast because I just saw the time. So going back to the quiz, so this seems like a patient who has hemophilia. So we would expect that their PTT would be prolonged. PT and INR is normal. Clotting factors that are normal relative to adults is actually going to be fibrinogen. Factor V is elevated in newborns, while the other ones listed here are decreased. And then factor with the highest rate of spontaneous intracranial hemorrhage is factor 13 deficiency. Lots of references, but thanks for coming. Sorry I didn't leave too much time, but I'm happy to stay on for a little bit longer and answer any questions that came up, because I know I blew through those things rather quickly.
That's great. Thank you so much. There was one question chatted in about the incidence of, I'm assuming it's thrombocytopenia in babies who are born to a mother with ITP. I think just question about how common does that occur?
Yeah, so if the mom has active ITP, so, her platelets are low, it's quite common. I would expect the majority of those patients to have some amount of thrombocytopenia. It's variable how severe it is. So they might just be very mildly thrombocytopenic, but we're actually following a patient now who's a few weeks old. Mom has active ITP, and the baby was born with platelets in the 20s, which are now thankfully in like the 40s. So we're not needing to do all too much after giving some IVIG. There's a lot of incidences for all these conditions. Let me see if I put in my notes kind of what the exact one was. So it's severe thrombocytopenia, so under 50, if mom has active ITP in about 9 to 15% of infants. I didn't put the overall one, but if mom has a history of ITP, the incidence is much, much lower. But even if mom is in remission, the infant can still be affected because there might be some antibodies still floating around. And that number I did not put down, nor do I know off the top of my head. Sorry.
No, that's okay. Any other questions if anybody wants to unmute? There's probably been Julia, do you have a question?
I was just going to ask if we could get the slides because they were really helpful. We all really thought this was a great talk. Thank you so much.
Oh yeah, happy to send it your way. Should I just
send them to me and
we're at UVM, so you can
the same program.
Yeah.
Okay.
I was going to ask you quickly, I know we're out of time, but there's been a lot of recent evidence from the neonatal world about the harms of platelet transfusions, and I was wondering what you use as your threshold. And I think it would just be wonderful to hear, not that I'm looking for a number, more your thoughts about what would be the downsides of platelet transfusions.
Yeah, so this was something that I did not include because I had enough stuff to talk about. But yes, as you mentioned, increasing evidence that as we have kind of a what do they call it, like a stricter platelet threshold in transfusing platelets, particularly in the absence of bleeding, is kind of the key buzzword, that those patients have worse outcomes. And at least trying to remember last time I read one of the papers on this, but they think it has something to do with just when you're transfusing platelets, there's often a lot of stuff within the soup that might be contributing to inflammation and making things worse, as well as transfused platelets really do have a short half-life. I mentioned it's 2 to 3 days of a half-life, but that's assuming there's nothing that would cause the platelets to be consumed. As an example of that, our patients who are undergoing a stem cell transplant, we're often giving them like BID, TID platelets because we dump platelets into them. And then 6 hours later, they have another episode of epistaxis, and then we're transfusing them again, or they're breaking out in bruises. So if you have a patient who say they have E. coli sepsis, they're having vascular inflammation and damage, that is going to come around and those platelets will be consumed much more rapidly. So I think there's also a component of if you're dumping platelets into someone where it's just being consumed in kind of a coagulopathic one that's not actually causing bleeding, you're also then at risk of fluid overload, as well as anytime folks get blood products. In pediatric patients, you actually have, and I don't know if this extends to NICU, I'm sorry, but I know it's in pediatrics, but you have an increased risk of actual transfusion reactions relative to adults. Adults, they have more like TRALI, or transfusion-related acute lung injury, than pediatrics. Kids, you have more likely like allergic type reactions, as well as some of the kind of febrile ones. I don't know if that extends to the NICU though, but I think all of this is coming together, and my hope is in the next like 5 to 10 years, we'll kind of elucidate the mechanisms a little bit more. I will say personally, and this can stay between us here, that it's very attending dependent on what they want to do in terms of platelet thresholds. We base it off of basically what's going on with the infant, their risk of bleeding. If it's a patient that has, say, NATE, much more likely to transfuse because we know their incidence of intracranial hemorrhage is so high. But in the absence of that, if the baby's hanging out with like a platelet count of 40 after we diagnose them with bacteremia and E. coli sepsis, and they're doing well, I might say, hey, let's just check like a weekly head ultrasound to make sure we're not missing anything. But by and large, most of those patients do well and they recover in time. This is where, as well as if you actually go and look at the peripheral smear, which your hematology colleagues can help you with, during times of inflammation, the number of platelets might be low, but we see that they have a lot more kind of larger, well-granulated platelets, which is showing that the body is recognizing that we have thrombocytopenia, and then they're trying to compensate for that. So that can be beneficial as well, because we have patients with ITP who, because they don't want to take Promacta, or they're just kind of waiting out, or walking around with platelet counts of like 5 or 6. And you have to struggle to find the platelets with them, but when you do, like, they are big platelets. They aren't giant or larger than a red blood cell, because that's associated with like Bernard-Solier, but they are quite large and they're always very well granulated. And so that's protective, and it's likely why we have folks with platelet counts in the single digits, but the incidence of ITP in patients, in pediatric patients, is similar to in the neonatal world. If the mother has, or birthing parent has ITP, where it's like 1.5% at most, in the absence of trauma or something else. So that was a very long-winded answer, but I'm in favor of kind of, loosening and not, transfusing if, say, the platelets are below 100 or 75, if the infant is otherwise doing well and there's not some other clinical reason for it. But some of my neonatal colleagues here might disagree with me on that.
No, thank you. That's really helpful. Yeah, well, this was great. Really appreciate you talking to us, and we download the recording to an ONTPD YouTube channel, so lots of fellows will benefit from your talk, and really appreciate how comprehensive and recent your evidence was. So thank you so much.
Oh yeah, I'll send you the slides, and if you can send me the link to the YouTube for that. I didn't realize this got uploaded there, but yes, happy to distribute this. And for
Yeah,
anyone
absolutely.
watching on YouTube, you know, if you want to look at any of the figures, there's 3 pages of references. Just pause the video.
Great. Yeah, it's you know, it's just our own channel. We used to have, we're moving to a new free online source called Open Pediatrics. And so eventually they'll be uploaded there. You know, just free and open to people engaged in pediatric education. So
Great, great. Well, I will I'm actually on heme consult, so I'm gonna check in with my fellow, make sure everything's okay, but